So today's session is as your LMC. So we've got Michael and James giving updates on the recently announced GP contract and then the LMC strategy and other work that we are doing for you best practices. So straight away, I'll pass straight over to Michael if that's okay.
Yeah, thank you, Emma. Hopefully you can hear me okay. So yeah, there's a few things we wanted to cover. So I'm going to cover two elements really today, and then James, as our medical director, is going to take you through some other issues as well that we've been working on for you locally. So I'm going to take you through some of the headlines from the GP contract changes for April. I'm presuming that quite a number of people have probably seen some of them, some might not, and of course we can have a bit of a question and answer session at the end of my part if you'd like to. It's quite sketchy still, so we're expecting to see more information over the coming weeks. And of course, what we'll do is put out more information to help you to kind of digest it. But there are headlines that I'm going to take you through. And I'm going to try, and hopefully this will work with the tech, but I'm going to try and show you a video from Katie Bramwell-Stainer, the chair of the General Practitioners Committee of the BMA, where she talks more about what the agreement on the current contract for April onwards means. Straight away, the welcoming thing is that this is the first agreement on a contract for GP contract that we've had now for about 3 years at least. The last 2 years from the Conservative government have been impositions of a contract that were not agreed. So this is an agreed contract, and it's quite different now from what we've become used to for the last few years. The other part of it is which I'll cover, is around what does this mean then locally? What does this mean nationally and locally for collective action? What does this mean for where the focus is on things like safe working, pushing back work, doing serving notice on work that's not funded? What does that mean for all of this? And what have you heard about advice and guidance and how that might be funded? So I'm going to cover all of this as best I can, and then invite a bit more of a discussion or any questions. And here we go. So I'm going to try and share this video from Katie. Please, guys, let me know if you can't hear it or see it properly, but hopefully it'll all be okay. And it's only about 5 minutes, just under 5 minutes. So it's not long, but it'll give you more of a grounding really on what's happening nationally on this.
Hi, colleagues. I just want to explain a bit more behind today's headlines. In case you've been stuck in surgery all day, GPC England has tentatively agreed a deal for 25 and 26, but only if Wes Streeting writes to all of us, setting out his intention to go to Treasury to ask for funds to negotiate a wholesale new NHS GP practice contract within this Parliament, which he needs to do before the special conference on the 19th of March. Because that's what we need if we're genuinely going to save and rebuild our profession back from the brink. I spoke to Wes Streeting, Stephen Kinnock and senior civil servants yesterday. We are on the same page, but we still need those written assurances. So too do we need the special conference of LMCs, because this is still a fragile deal with a lot of hope and goodwill needed. 3 areas are going to require immediate ongoing work to determine our next steps. One's around online consultation excess, which is a red line for the Secretary of State. It's given him the headlines this morning that he wanted about fixing the front door to the NHS and ending the 8 a.m. scramble. It does not mean that we're going to have to find unlimited capacity for same-day urgent care. We have warned government repeatedly this policy risks leading diminished GP access and increased GP waiting lists. We've got a working group that's going to look at how this can be safely managed and what's needed from online platforms to safely mitigate the risks and manage the demand and capacity mismatch. If we aren't there by the 1st of October, then we'll need to return to the negotiating table. Number 2, GP Connect. The plan is for NHS registered pharmacists to gain access to write in the record for Pharmacy First. Their clinical decisions mean their liability. And for third parties to be private providers working under NHS contracts, but we need to be very careful around defining direct care. My sex worker patient who gets her ears microsuctioned at Specsavers is not going to want her full history shared. We're going to need to embed Caldecott principles here before we can be sure it's safe to switch on in October. The Joint GP IT Committee will be taking this forward with GPC England. And finally, GPs in ours. Yes, it's still crap. It was NHS England's red line. And no, it's not improved. Do you want it to improve? We want money going into core so that more GPs can be recruited into practices as salaried GPs and partners, not spread across God knows how many practices and 50,000 patients. There's now a single R's pot. Split it equally between your practices. Spend it on the roles you need. If you decide in the future that you want to restructure your teams on the back of this, then please follow strong HR principles and sound employment law. The BMA can and will help, but just take stock first and don't rush. The money. The headline money is helpful. It's 889 million. And then there's the 80 million around advice and guidance on top, all in 1 year. That 969 million headline in 1 year compares very well to a very similar number that was spread across the 5 years in the PCN DES. But the big deal is a new substantive contract. So what does this mean for collective action? Well, much of the collective action menu will be superseded if 25-26 goes as planned. So we'll need to update it, reframe it and consolidate it around safe working guidance principles, which have been our policy for the past decade, which is still our policy, and local contracts and commissioning gaps, where your LMC is vital in galvanising collective bargaining. We're no longer in dispute with government, but that cannot and should not get ICBs who are perpetuating these commissioning gaps off the hook. So we shall shift our focus accordingly. So ultimately, this is a promising start. We are on the train towards recovery. We are not yet at the destination. In fact, we are miles off, but at least we are now finally heading in the right direction with a government that is listening and a government that is acting on what we've said. Enjoy your weekends and we'll speak soon.
Okay, so that was a grounding then. That was an introduction. This was recorded, I think it was early last week, maybe the week before. So that was an introduction into what's happening over the GP contract. So as you heard there, 969 million pounds put into general practice. 80 million of that is the advice and guidance. So effectively from April, if you're making an advice and guidance request, then you get £20 for that. Sounds a bit silly, sounds a bit odd, but it's interesting. It's been taken out of secondary care budgets. That's quite a difficult thing to do. It's normally met with a lot of resistance, but that's where that money's come from. It's actually come out of secondary care, coming into general practice. So each time you make a A&G request, you'll get £20, and obviously that will you'll have to think about how that's coded, and we'll get more details. That doesn't mean, of course, that everything that you do has to go through A&G. So what we've got to be really careful of locally is that we don't see contract changes as being must-dos. We don't see that A&G attracting £20 fee means you can't refer and insist on a referral. Of course you can. You still can do that. So it's more that that I think that the BMA have been saying to the NHS England and to the Secretary of State that they're doing all of this work that helps with the interface, that helps with efficiencies, and not getting anything for it. And then they've managed to get some money for A&G referrals. So it doesn't mandate you to have to do A&G, but it's now getting you some payment, albeit that we might have arguments about how much it should be. So that's welcome. It's interesting when we hear about money being put into general practice, we've got to remember that when we're talking about PCNs and R's monies and all of this, that it's still counted in as money into general practice because it's a DES. It's a DES, a national DES that general practice can access and get more money into the practices through. So it is seen as the same in a sense. What we don't see is all of that going into global sum. So that was mentioned on the call there, really, on the video, about when we talk about global sum and the core funding. That's what we mean by the money that goes into your account, into your practice directly, without having to do extra to get it. And that's the bit that's weighted against what's currently the Cahill formula, which may well be superseded by some other method in the next year or two. We don't know yet, but that's not been updated for some time. The bit around the GP contract, the overall part is that this is a useful step forwards, and that's what you heard there. This is the government listening. They've only been in post now for what, 7-8 months, so they haven't had a lot of time really to get stuck in and to reverse the years of underfunding of the previous government. They haven't had time to do that. So So far, it's interesting. I mean, I'm only talking from a personal opinion point of view now, but I do talk a lot with Katie in the BMA, and we do work across the UK and in LMCs. We know that a lot of the response so far has been muted. There's a lot of people who feel that this just hasn't done enough, and I think there was an expectation that many people had in practices that actually all of the collective action that was being undertaken was about April this year. I think what's been really clear from the noise from the BMA over the last few weeks is that that was to get us along the line of a better place for general practice, but realistically, that wasn't likely to happen for April. So this contract isn't the stop and the end of everything. This isn't a case of we've all worked together for a while now to bat a lot of stuff away, to make it more difficult for commissioners and to get some headlines for the government, and that's going to go away now from April. That isn't the point. The point is that the BMA are no longer going to be in dispute with the government from April. So they won't be. It's a new contract they've agreed. So there won't be a dispute with government from April, provided that government signs up to say that they're going to commit to writing a new contract with the BMA within the life of this parliament within the next few years. So what that looks like, we don't know. This would be the first new contract since 2004. So for some of us who have been around long enough and seen that, that was the new the little N, the GMS contract, the new GMS contract that came in 2004, and that's what brought in things like GPs not having to provide their own out of hours, etc. So it was quite a big contract change. But now, we're over 20 years away from that. So we're in a situation where our BMA right now with the GPC are aiming to get a new contract in its whole entirety, rewrite the contract, not make changes every year, which is what we do and what we've had again this year, but actually completely redo the contract. I've been in some BMA workshops as with the LMC over the last few years, where we've talked about what can a new contract look like. So there's been lots of different ideas about this. There's been ideas around the fact that it's really difficult to cost a contract that's a block contract, which is what your core contract is. You get paid an amount and you see your patients and you do what you need to do against that amount, irrespective of how many times you do it. So there is talk about, could there be an item of service element to it? Could it be that all the work you do gets quantified and paid for according to how much work you do? Equally, could you do it as a bit of a hybrid offer? Could you have it where there's an element of core funding, which is in a block, and you get that irrespective, and that's based on your population numbers, but also an element for item of service? Could you then have an element of your core service costed up, coded, and paid for according to what you do? I don't know what's going to be negotiated. All I can say is that all of these different scenarios are being worked on and modelled for a new contract. So if that's what we're going to get over the next few weeks, and as you heard Katie say there on the video, she wants this done by the special conference, which is next week on the 19th. So if we get that pledge and the BMA get that pledge from government that they will work on a new contract to be put in place during the life of the government, then we're going to see some changes. Then we're going to see something different, hopefully better. So, what I would say is that this doesn't answer everything. This doesn't put us in the situation where suddenly all of the GPs who are finding it hard to get work are all sorted out. We know that's not going to be the answer. That's not going to be here yet. But hopefully we start seeing some of the most acute problems in terms of funding and practices keeping afloat. We hopefully see the edge taken off that in some ways, and some extra flexibilities in the PCN DES. But we need more than that. We know we need more, but this is a start, and it's a lot of investment from a government that is not like investment we've seen for a long time. So it's not to be happy with something that's substandard, but it's almost to say, look, it's encouraging. We're on the right track perhaps here, but there's a long way to go. So hopefully you've seen a lot of the news on what's in the contract in terms of next year and where we expect it to go. Hopefully you've seen it. But some of the headlines that we've seen and are on the BMA's website are around, excuse me, practice nurses being added to the main R's scheme. So that's being talked about. Again, interesting how you feel about that. There's uplifts in the minimum GP salary and reimbursements on that. So again, one of the criticisms for the R scheme for GPs was that it just didn't pay enough. It just wasn't attractive. And obviously the other bit that in your PCNs you need to think about with ours is that, okay, you get people moving into those roles, but how are you going to deploy them? Are you going to move them so that they're based in one practice and do equal work for each of those practices? Or will they work on project work? Will they almost be like a locum for the PCN to tap into? There's different ways you can do it. So, we might get in the same position with practice nurses if that's going to be introduced as well. Excuse me. There's an uplift on the statement of financial entitlements payments. So this is payments around sick leave and parental leave, etc. In terms of reimbursements that you get, your locum reimbursements, which is being uplifted with the real times values for this year. So hopefully we're going to see a decent uplift on that if you ever have to use it in the case of absences. And that's important. It goes up from between 15.9 and 17.1%. That's what we've been told. We've still got to see what the DDRB is going to recommend. So the DDRB is the remuneration body for dentists and doctors. So they will have a chance to say what they think should be going in additionally for general practice, and then it will be about whether that's introduced. And we've also heard that in the House of Lords the other week that they voted through to exempt general practice from the national insurance uplifts. That doesn't mean it's going to happen. It does mean, though, it does make a headline. It does signal an intention and a fairness around general practice getting treated like other NHS employers and being exempt the NI lifts. We don't know if that'll happen. It still has to go through the House of Commons. So we can keep fingers crossed and hope that it does. And if it does go through, that will make the contract a lot more attractive in terms of the global sum payments. But we don't know if that'll happen. And we know that the government was against making that exemption. So they may still be able to block this, even though the House of Lords have voted it through. There's a change in QOF, so changing 32 indicators worth 212 points that were frozen for last year, and they're going to be permanently retired. And that's going to be split across the global sum and a renewed focus on CVD indicators. So there are changes in that in terms of some of the thresholds. We didn't get the changes where we needed exemption reporting for child in IMS. That was something we've all been talking about for a long time now. And it's disappointing that hasn't been resolved with this. So we need to make sure we keep banging on the drum to try and get that change, because that is so almost impossible for people to make. And I think the answer that's been coming back to the negotiators on why that's not been lifted is because of that worry about exemption reporting and people being missed. Actually, what we would say, I think, locally is that you've more chance of having a public health issue with vaccination for kids not being high enough by not allowing these exemptions, because practices might naturally do a bit less in terms of trying to get these numbers through, because they find it hard to achieve some of it. So it's a really odd way of thinking about it from the government's point of view, but that hasn't changed, unfortunately, in QOF. We really wanted it to. We know the BMA went into bat trying to get that. It didn't happen. From October are the changes over the online access. So we've heard about that. That's non-urgent appointment requests, medication queries, and admin requests. So that's got to be and that's during core hours, but that's got to be sensibly implemented if it gets implemented. And I know the BMA are going to be working hard to try and change the way this is done, because there's lots of issues around this that from a patient safety point of view and from a workload point of view. We don't actually need another lane on the motorway to be opened up to get more ways of you getting more work. So that's not here yet. That's October for in hours. We'd like to see that removed, or as a requirement contractually, we'd like to see it removed, but that's up to the BMA to try and negotiate that through. Then we've got the R's. So we've heard about practice nurses potentially coming into R's as well as GPs, and changes in how that's going to be paid for. Vaccinations, there are some uplifts on that, but this will all come out in the full detail. You can see it on the BMA website. We can share that link, so you can look for yourself. But these are your headlines. The £20 per item of service fee for A&G requests, advice and guidance. So as I said, please remember that this doesn't mean that you have to use advice and guidance. It just means that when you do, you get a £20 item of service fee for doing so. And that's lifted from secondary care budgets. That's the really interesting bit of that. That's not from our existing budget. That's taken out from somewhere else. Normally quite a hard place to get money from. Collective actions, we heard Katie say on the video, what does that mean for collective action? Well, they're going to reframe it. They're going to change the way they use it. And as I said, they're not now in dispute from April with the government. So collective action isn't trying to hit the government and try and get them to do things, because effectively that's kind of worked to some degree, that they've got an agreement now on the contract. And that was what the aim of collective action was initially, on to get an agreeable contract that you could work with. But it's not quite where collective action was designed to get us to. And that's why, I think that's why Katie's made clear on there that there's a reframing of what collective action is. It's not saying it's all gone. It's not saying everything's all right. We don't need to do anything else now. It's saying that this is a good start. A lot of the things that were done during collective action, I'm sure BMA will still push to do. And locally, we were not going to push you into what to do, but we are going to encourage you to keep using some of what was in collective action as business as usual, irreversible changes that you've made to the way that you work. So safe working is naturally part of that. If you've been safe working and if you've been making changes and you've been thinking about other changes, nothing here should change that, because that's right for you. That's right for your practice to serve your patients in the way that's best for you. That shouldn't change. The thing around bureaucracy, paperwork, having to do templates that get in the way, if you've stopped doing some of that and it's still enabled you to get your patient the care they need, why would you go back? You don't need to go back if it's worked. If it hasn't, you need to let us know and we need to try and iron it out, but don't go back on things that have worked for you. And probably the most impactful part, I would imagine, has probably been the bit around stopping doing work that isn't paid for, that isn't contracted. So some of the services you've been doing and be pushed onto you, and you've started to look through it and gone, I don't think we actually paid for this, and then you serve notice on it. We'd encourage you to keep doing this. We think that needs to still happen, because we don't want you working for free in a system where you're not getting paid enough. Because if you do keep doing it, there's no incentive for the government or local commissioners, more to the point, to commission it properly. Why would they commission something properly if most practices are doing it for free? There's no impetus on them to do anything different. So keep doing these things, whatever you want to call it, whether you call it collective action, whether you call it just trying to make general practice more sustainable. Don't stop doing it. Don't stop doing the right things for you and your practice. It's not a protest against the government anymore if we get this promise of a new contract, but it is still saying to the ICB that we're not going to stand for work that's not commissioned properly. And as practices, you've got to be prepared to step away from stuff that isn't commissioned properly and make your own decision on the cost effectiveness of it. There's no incentive for anyone to do anything different from the commissioning side if we keep doing it and making it easy. So we can advise and we can support and we can give you help with that, but it's ultimately your decision in practice as to what you choose to do. So collective action is going to change. It's going to be more about getting the right things for the future, but don't go back on the things that have been helpful. That's got to be the message. So that's the headlines. And what we've done in the past is we've often done joint presentations with the ICB or the CCG, as it used to be, on changes to the contract and what that means locally. So I'm sure that we'll be doing some kind of work over the next month or two on making sure that it's very clear to you as to what's in the contract, how it's being implemented locally. But the real point now is that, we've seen some useful things. Have a think about that. Have a look at when you see the money come through, when you see what it means to your bottom line, just have a look at that. Have a look at what that does for you. And we really hope that we can get some of this NI shift gone as well. The minimum wage stuff, that was never going to be changed. We could never really get exemption from that. That's a national change. But the NI, we've still got to keep fingers crossed that we could get that moved out and keep exemption for general practice. But what the chances are, we don't really know. It's very hard to say. So some good things in there. Keep doing the things that protect you in your practices and help you to deliver safe care to your patients. And remember that the GP contract is really permissive. It gives you a lot of latitude to do things that work for you in your practice. And when we hear things and people making, there's a lot of discussions we have on the WhatsApp group and a lot of discussions around what's contractual, what isn't, what's core, what isn't. Just remember that the descriptions of essential services, which are your core contract, are around chronic disease management, are around patients who are ill or believe themselves to be ill and are expected to recover, or people who are terminally ill. That's your core contract. They are your core contract activities. And then there's additional services. So there's things around kind of, maternity and others as well, around childhood vaccines and things. So there are other avenues that are additional services that are tagged onto your core contract. And we'd expect those to be part of what we do anyway. Apart from that, anything else it's got to be non-contractual, and then it has to be funded properly if you're going to do it. That anything of these new things that come through, if they don't fit into that category of essential services or are not in the list of additional services, then they're not contractual. And generally speaking, we in the BMA regard that if these services are being commissioned elsewhere in the country, then they're clearly not contractual. And we tell the ICB that, and we show them examples of where they're commissioned elsewhere and say, look, they're doing it. That ICB has commissioned it, or that provider has been commissioned to provide that stuff. So that's not core service. So don't expect practices to get on and do it, because they don't have to, and it's not part of their contract. So let's keep that tight. Let's keep looking at what you're doing. Don't accept unfunded work. This is our advice. It's up to you. You're the contractor. But remember, you're in the contract with the NHS. You're in contract. That means you have things you should do. That means you have things that you shouldn't do, and you should be paid additionally to do. It's quite a hard concept to get around when you feel like you're part of the NHS family and using public money, but you are a contractor. So that's probably my bit for now, really. I think we will send out more information on the new contract as it lands, as we get more info. We know the headlines, we know what we think's coming, but we need to see it in black and white. And really, I guess, Emma, Stu, anything more that people want to ask or is in the chat, very happy to take it.
Thank you. So there's just a question around whether the cap on the advice and guidance payments, and whether if we know anything about our local ICB and how they're going to implement it. But James has answered that we understand there's going to be a budget provided to the ICBs, but we haven't got any details of this yet.
Yeah, correct. Yeah.
And then there's a comment from Debbie Swain. She said that she's a bit worried about dressings at the One Voice Forum.
Okay, did you want to expand on that, Debbie?
Oh, hang on a second. Yeah, sorry, Michael. So when we was on the One Voice and was talking about the SDS, they did mute compression dressings, which obviously would be a deal breaker for us. So I mean, there was nothing definite, but it seems to be on the table.
Yeah,
as a discussion for later, and it's huge to bring back in compression. I don't know if there's any practices out there still doing compression and Dopplers, but we've not done them for a decade.
Yeah, I mean, this is the problem, isn't it? So there were headlines at that One Voice Forum, but we still haven't seen the full spec they're taking to execs, so we can't say what they're planning, really. So we do have regular meetings with the ICB. The team have got one coming up. We've got one with the leadership. Myself and James meet with the medical director and deputy. So we want to get well ahead of this. If that's on the plan, we want to know that, and we want to know how they're going to do it. But as we said before, we've got to make that distinction between what is contractual, what isn't, how they commission it. But what we really want is ESDS fit for purpose. We really want the dressings part pulled out of ESDS completely and funded properly. I don't know if that's going to come in this offer. I hope so, Debbie. But do you know what? From what we've heard in those discussions, I haven't got faith in it that's coming out.
I think they'd be mad, Michael, to separate it, because then that's the risk people not doing it, and there's just no other options. It just concerned me how we're certainly struggling with dressings and volumes, especially in Newark. Newark seems to be pretty high because I've spoken to district nurses about it, an urgent care centre, and yet they seem to be then talking about adding to that a little bit. And it just threw me completely, because I wasn't expecting that discussion at all. And it just felt like you go on these things to say how much you're struggling, and then it just kind of blindsided me a bit, that part. That could be a possibility. Yeah,
and we'll keep talking. We'll update on these meetings when we find out more, because yeah, as you were, I was surprised that was coming out. And we've had, and let's be frank, we've had discussions, and I'm not going to go deep into it, and James might want to expand from the medical director point, but we've had discussions where we thought we were getting into the right place with the ICB, the other obvious one being transgender prescribing. And we've seen briefs, we've seen copies of potential services, leses that can come out with some costings, and we've commented on them. And we still haven't seen a final one come out, and we know it's still bouncing around the ICB. So I'll let James come in and maybe talk about that later. But when we think we're going in the right directions, there is resistance to some of this for sure. So we keep going, and we'll keep you informed as to any of this. But obviously, ESDS isn't fit for purpose. Where we're at is, and I think practices know this, but just to reiterate, so we're halfway through a 2-year deal on the ESDS. So we're halfway through a 2-year contract. So at the moment, if nobody changes anything, then the current offer you've got is what carries on past April. I think that these changes we've been pushing for ages, I think they're going to come out really late. And I don't think we're going to get much chance to look at this before April. And it might even be that it's just after the 1st of April. I don't know. But it'll either come out very late in March or early April, I think. So what will happen is that you'll have a choice in practices to almost novate your contract. So you'll have a choice to go, okay, I'm halfway through a 2-year contract. I don't want to stay on the old terms. I want to go to the new one that the ICB have put together. And then you'll have a choice as to whether to jump to the new version, which hopefully will be uplifted and hopefully will have some favourable terms in it. But I haven't seen it, and we've been talking about this for a good long time. What we've got to get from the ICB, in my belief, and I know James is working on this, and we're all working on it, but is to get a bit like the GP contract at national level. But we need a change in how this will get commissioned for the future. And I don't think, when we've asked them frankly, Debbie, haven't we? We've asked them frankly about getting an item of service line by line contract, and what they were really honest with, which was helpful in one way but scary in another way, was that they didn't have the baselines, they didn't have the costings to be able to give us an itemized line for line contract where you could opt in and out to get the work done. And you've offered, and we've offered, to come in and help them do that. And so that's what I want to get for next year, where they give us a quantum of money as a minimum startup point, and we start working on engineering something that we think we can deliver. And that's part of the point of the idea of a GP collective, where we start seeing problems and we say, look, give us some of that problem to sort out, because we think we could do a lot of this, but we don't agree with how you're doing it. So we could do the costings, we could do some of that work, and get that budget and do it in a way that we think is doable. But that's what we've got to negotiate with them, that we get the trust and the chance to do that, because what they're producing isn't good enough.
I think the thing that worries me is if this contract comes out and then practices feel like they've got no choice again to do it, and a bit like the NHS health checks, I think a lot of practices thought, oh, we'll end up with all the blood results and everything else, and it's just not been made absolutely clear at what point the work comes back to us or not comes back to us. So it's just a bit of a worry that there's not always a full understanding. So if they come out with something this time, it almost makes it you have to jump onto it. It gives you no choice, and then you end up doing the compressions as part of it. We just don't know what's coming, do we? If they're giving us a choice between the old one and this new one, there's going to be a catch, I think.
We'll need to see, Debbie. I don't know. I mean, at the end of we know that it doesn't feel like a choice, because a lot of people's staffing is based on some of that income. A lot of people feel that income's better than no income, even if it's costing money to do the work. So it's not simple. I'm not going to simply say you do have a choice. Of course you do. You could choose not to do ESDS, but we do know that there are players in our system who would offer to do that work. Whether it's successful or not, that's not the point. But we know that the ICB knows of other ways of trying to get this provided if practices don't do it. It's really hard. I think it would be great if all the practices sent notice on it and said, we're not going to do it, and now you have to come up with something better. But we did run a poll on this last year, and the appetite to do that was really low. I think
my worry
really
is there's not even going to be much of a choice between the old contract there and this new one coming out. They're going to force that way, but like you say, we'll just have to see. Yeah, but we need. I think we just need, when it does come out, like full transparency on it. If there's nothing hidden in it, like the NHS health check one.
I agree, but we've also got to be good at pushing stuff away. It's and a lot of practices have really been good at this in the last few months, pushing stuff away that shouldn't be coming in and saying no to it. And the ICB are getting used to this now. They're starting to get used to the fact that every few weeks we're telling them of something else that they are not going to be getting anymore for free. And what we will do is we've pledged to do this now, but this thing around having a very clear list of services that are not contracted, they're not part of your GP contract. We're doing our best to get examples of other areas who are commissioning it so that we can prove it, and then we can have a list of them, send it out to you as practices and say, look, okay, your option here, if you want to carry on doing it, fine. If not, please sign this, and we'll get it back to the ICB. Or equally, we just go and negotiate it. So we need to get that mandate to say, look, there's 5 things here that practices won't carry on doing. This is the notice for it. But actually, there's probably a will to do some of it if you resource it properly. So let's have that conversation. So it's changing. The good thing about collective action is it has changed a lot of the thinking around the money that practices get and how they get paid. And I think that alone has been really helpful. And the ICB are definitely of the mind now that they're expecting this. They're expecting practices to serve notice, and they're thinking, what the heck do we do? And that's a good position for us. We need them to be thinking, what do we do? But, there's so much control that you've got in the practice. But this is the worst part. We know that practices will do work that isn't properly funded because it's better than not getting that money and maybe having to think about really difficult staffing choices, which people don't want to do. So
thanks.
That's difficult. We know that. Emma, was there any more that we need to pick up or any questions?
Just some comments. Andy agreeing that they spend a lot of staff time in dressings and increasing it would be unacceptable for them. And then from Khalid, it needs some sort of task etiquette. Often this is a way of unsourced workload shift, which they have no control over.
Okay. Yeah. Okay. Can't disagree with that. So this is the interesting bit. We are. I think the focus is around what we do locally in the future. I think it's less about national because they're going to be working on a new overall contract. I think it's going to be about what we do locally with our commissioners and how we make that happen and how we stand together on that with our practices. And we can advise. I mean, when we speak for you, it's because we're listening to you and we're trying to get what you're asking for. We're not a provider in our own right, so we don't agree a contract, but we'll say that we agree with the contract. It's up to you now if you want to do it. So it is slightly different. The other thing I wanted to update you on is just SMS messaging. So we had we've had a recent presentation on this, and we've heard the ICB saying that the cost of text messaging from practices has escalated wildly, which it has. I think that's good. I think it's good that practices are taking it up. I think it's good that patients found it helpful, but there is clearly an exponential rise that they're worried about. So the ICB have been saying that they're going to move to a system where they give a contribution instead of pay for the whole costs. And that would mean quite a lot of extra expense for a number of practices. So we've been in contact with them over the last week to try to persuade them to change their stance on this, because we want to work with them. We know that there may be examples where there's messages that are costing more than they have to in terms of the way they're used. Some of should there be rules over what you use it for so that we keep the cost down? The sense we got from the conversations was that everyone was going to get punished for what potentially isn't everybody's usage. Why should you lose all that funding for the work you're doing when you're using it really well, sensibly, within some boundaries? Is it fair to get punished and be treated the same? So we've persuaded them. We're waiting for formal notice so that you get this formal notice. I'm hoping it will be by the end of Wednesday, but let's keep pushing. But what we feel we've agreed is a postponement of that decision. So we feel that that's going to be put off for 6 months. That's what we're being told. That's after us campaigning for you to get that put off. So we think that we've got a 6-month stay really before that gets put in, and we hope we can avoid it. So what we're going to do is we're going to work with the ICB and with Paul Miller in the department there to work with them over what the SMS is being used for, work with them over things like the NHS app and how that's working and how people are using it. and look at guidelines for how the SMSs are used and for what, and and some of the things that cost more money that maybe not everybody's aware of in terms of duplicate numbers, unreturned texts, and things like this, and the way that the packages are made up in terms of longer messages costing more. So we're going to work with them on this, and we've pledged to do it because we don't want you to get passed on that extra cost. If that means we have to work with them to rationalize it in some way, or make it easier for practices to make decisions to reduce the overall cost but still get good impact, then we'll do it. And if that means we get it held off for 6 months and then we get it pushed away completely because we've mitigated some of that extra expense and brought it down, well, great. But we'll work with you on it and we'll work with them on it. But that's what we think we've agreed. We need to see it in writing so you can see it in writing. But we think we've agreed a 6-month stay, really, where we don't get that imposed, and we can work with you and the ICB on sorting some of this out. But it's a good news story in that it's being used a lot more. It's been very helpful for a lot of patients. We don't want that to change, but possibly there's ways of making it more efficient, and we'll work with you on that. Now, I'm mindful that we've just gone 20 past. So I'm going to stop now unless there's any questions for me on that. But I'm happy for handing over to James now, our medical director, James Hopkinson, who's got other areas he wants to update you on.
Thank you, Michael. I think I'm off mute. Yeah, brilliant. Afternoon, everybody. Just a quick update from me, and hopefully there'll be a bit of time for questions at the end. So I guess from my point of view, there's a deal agreed between GPC and government, but nothing changes. Our LMC strategic aims are still safe working, reducing the workload shift, and financial sustainability. In some ways, I'm more comfortable with it now because I found the idea of collective action using things like safe working as a lever uncomfortable because I didn't see it as a collective action issue. I saw it as a important issue that doesn't go away. And for some, in my head, collective action was a thing that you did in a bit like industrial action. You do until you get your win, and then you go back to what you were doing before. And for me, the concepts of safe working, managing the workload shift, and looking at some of the finances as all core things that we're never going to stop. I accept things like turning off script switch and things like that were in collective action were things that we're going to possibly reverse when we stop being in dispute. But those bits are now more comfortable for me. So few headlines. We've mentioned a little bit of already because we've strayed into some of that stuff. Starting with, I'll just cover ESDS first because a lot of that discussion's already happened. There's been loads of engagement, loads of meetings, loads of discussions, suggestions about taking bits out of the contract, whether that be dressings, seeing if we can have tiers of things, whether there's some way that we can actually have an activity base for certain areas. I think we've had so much support from the ICB in the fact that they've listened to us. It makes me feel slightly positive that they've listened. But until I actually see something on a piece of paper that tells me what the costings look like, it's really hard to actually know what's going to happen. This is a live scenario. It's going to go to execs shortly. I think it's either this week or next week. I'm not sure about that. But until we see it, I can't comment any further. I do know there's a reasonable uplift in there, but I don't even know what the numbers are. Transgender. Right. So transgender became an issue locally for us just before Christmas with one practice report telling the ICB and their patients that they were going to give notice to the trust, then hit all the media. ICB got a bit anxious about it all. It became an issue and we've had loads of meetings there. In the meantime, it became a bit more of a national issue with other areas starting to have the same conversations. NHS England have confirmed that although they commission the gender clinic, they don't commission it for prescribing or monitoring of medication. And they also accept it's not GP's job. So it's almost in black and white that there is a commissioning gap. And that commissioning gap is for the ICBs to fill. The ICBs, I think, have been dragging their feet a bit here because they're trying to see what's going to be happening nationally because there is talk of a national solution. I think, well, I do know that there has been 2 different versions of a document written because I've seen them with funding associated for delivery of that gap. In between those 2, there was a statement from the ICB to me that this was going to be, it's actually just core general practice work. So we don't need a LES or a DES or a third party doing it. That seems to have flipped again, and I know there is another paper going to the board on Friday. So hopefully we're going to get this sorted in the end. It's just slightly linked issue while I've got people's attention. I have been having some conversations with the Notts Healthcare Trust, who manage locally the gender identity clinics. Obviously, it's nationally funded, but they work for Notts Healthcare. And I talked to them a little bit about some of the tone of some of the letters that have come out from the gender clinic, which were, in my view, slightly bullying, and maybe some of them less so slightly bullying and just bullying, and being quite aggressive in their language about their expectations, and even quoting people considering their GMC status and stuff like that. Really quite inflammatory stuff. She's asked me for some examples of those that I can then take back. Now, I've got one that has been sent to me, but if anybody has any of those that they're happy to anonymize and share with me so I can share them, that'd be really helpful, because having made that comment, I'd quite like to be able to back it with some fact. So if you've got one, please can I have it? Moving on quickly. I'm doing a piece of work with NUH via the interface group. And I say I, it's the royal I, it's the we, really. There's quite a lot of people involved looking at DNAs. So there's been lots of frustration for many years with GPs when people come back to general practice to say, I need to be re-referred because I didn't turn up, so can you do me another referral letter? And I've been fighting NUH to try and start the process of getting them to internalise that process. So if someone doesn't turn up, why can't they just phone the hospital? Why do they have to come and see me to write the letter to press the button process? The first position from that was, well, this is a very complicated issue. There's loads of different reasons why people DNA, but I'm persisting with that point. It doesn't really matter what the reason for it is. Why does the solution need to involve me writing another letter from primary care? So they take that on board, and we are looking at it. And I'm now part of a little working group that's going to move forwards and doing that. And I'm expecting that to spread more widely. So we started off with NUH just because that was the interface group that I was sitting in. Duplicate letters. So we did an audit in Calverton over a 4-week period, looking at the number of duplicate letters that came through our practice. And in 4 weeks, it was 134. And when I printed them out, it was just over a ream. So it was a proper stack of paper. And working with my coders, we reckon that was about 5 minutes admin on average per letter, which is 11 hours of unnecessary work for one practice. So I've shared those with Jeremy Lewis, who's one of the clinical leads at NUH, and we're going through those, and he's going to go through them line by line, because his first question was, which department is it? And the answer is, it's all of them. So we're going to go through those and see if we can actually find a way of turning those down a little bit, because that just feels like an easy hit. I'm sure what's happening is paper letters have been digitized, and we still send paper, still comes digital, but we've definitely got appointments where we've had 2 digitals, 2 papers, and until you've scanned them in and coded them, you don't know you've already got it. So it's frustrating. What was else on my list? I'm just jumping around a little bit to try and fill in the gaps from what Michael said. I refer. So I refer is continually frustrating. So Andy Summers has been doing some stuff with Sherwood Forest on some specific cases that haven't worked. Ben, who's the medical director of Derbyshire LMC, and myself continue on the sort of the main I refer regional committee, trying to get some change. We're still fighting really for it to be turned off until it's fit for purpose is our starting position. But we're not getting very far, is the honest truth. Our only real win so far is putting an other box on some of the referral processes, so you don't have to lie to get your referral through, at least, which is a good start. But we still think it's unnecessary and does very little of benefit for primary care. But those meetings are ongoing, so I will carry on pushing. Talk about a little bit about engagement. So certainly Sherwood Forest engagement has been improving loads. Andy Summers, who's on the call, I think, has been doing loads of work with Sherwood Forest, and there's clearly a will with Simon Rowe to try and improve relationships there. And I think it's actually catching up faster than NUH formed their interface group now, which I guess isn't a surprise because there's something to follow. But it's getting there, and it's actually showing some will to do well. So I'm really pleased. Diabetes. So the diabetes les, which we've seen several versions of, hasn't yet been fully ratified. There is an uplift in the diabetes LES that I've seen. We've changed a change in the way the funding is going to work. I don't think the funding as it stands fits what we were hoping it could do to try and cover the costs of having a diabetic nurse. There is a substantial percentage uplift, but doesn't get us back to the sort of levels that we were really looking for. So I think when we get that officially replied to us, we will see an uplift, but we'll all have to do our own sums as to whether it covers our costs and what happens next. Again, that's been brought to a head by one of the practices whose diabetic nurse is retiring. So they have the challenge or opportunity of saying, well, actually, what happens if I don't replace her? Or what happens if I do replace her? And the cost of replacing her against that LES would be a lose money situation. So those sort of decisions are slowly starting to happen. And the ICB are watching this in real time, because up till now, everyone's just grumbled and signed up. There are going to be some instances, I think, where that's going to change. I talked really quickly because I thought I hadn't got very much time, and now I think I've gone through my little list. Emma, I saw the chat was just going up whilst I was talking, but I didn't read it. Is there anything in there that I need to pick up?
Yeah, so a couple of questions and comments. So on the duplicate letters, are there any plans or progress to move away from GP access for letters? Ideally, we want NUH letters directly into the clinical system.
That feels like a holy grail, doesn't it? There's discussion about it. Clearly, there's challenges, and there's certainly challenges that we see already with patient accessibility to the letters and the ability to hide them and all that happening appropriately. I think in the short term, the answer is no, but it's on the table for discussion because it's a national debate, really. But those conversations are happening.
Thank you. And then on the DNAs, Debbie Swain's put in the chat that they're not turning up because the patient doesn't know. They're sending it through the NHS app. Karen Fern is on the Sherwood Forest interface group, and they're working on DNAs. So I think Stu has linked you both up to sort of engage on that.
That's great. I think NUH are engaging with Sherwood Forest at a level to make sure we're doing the same work. I think because there's the same issues. Going back to the patient not knowing because they're sending it through the NHS app, the NUH position was this is really complex and needs a year's piece of research to look at why the complicated reasons why different socioeconomic groups don't turn up, and is it due to language complications? Well, my personal experience of this year is I've had one telephone appointment not happen, and then I was DNA'd because I didn't turn up in the outpatient clinic. I had an appointment for a scan arrive the day after my scan appointment was supposed to happen. You know, there's really basic, simple stuff that needs sorting out, and some of this actually being able to reflect it with some real examples it's been quite helpful. But I was a consultant at Queen's. When I was a consultant at Queen's, I had a secretary who ran my waiting list and she booked my appointments. And whilst I was there, everything got centralised because they could use cheaper people in central appointments to book my waiting lists. And my DNA rate went through the roof. And I'm sure it's linked. And you know, my secretary clearly was mortified if something went wrong and something got sent out to the wrong place. Now it's a faceless organisation that's managing that. So I think there's a little bit of learning that is happening about how and when these things happen. And it does impact on GPs, which was why we've raised it. So, and it's clearly impacts on patients. So it's a win-win all round. Massive issue for the trust. They lose loads of money because people don't turn up. They have to book them again.
Sorry, and then no, I was going to say, so then just another comment has come through that the appointment line number and many NUH outpatient letters for patients does not work. Tried it repeatedly and nobody answers.
Yeah, I've had that direct experience myself when I phoned the consultant secretary and it wasn't their phone number that was on the letter. So yeah, I've had that. There's all sorts of it's just some basic accuracy stuff that makes a difference, isn't it? Yeah.
Any last questions at all from anyone?
Helen Davis has put, I'd be interested if there's a correlation between DNRX and IMD, and there is. But there are some basic stuff as well that could just be got right. And that's the complicated stuff that they're looking at to tackle, and whether we can do things in different ways for certain groups. But but that piece of work will go ahead, and we do know it's true. Right, I'll shut up. Sorry, Emma.
Thank you. No. Sorry, thank you for spotting that one. Any other questions or comments at all? Okay, well, hopefully that was helpful. Thank you both, Michael and James, for coming on to give those updates and go through sort of what is happening, what we're doing, and locally and nationally. Next week, we are joined by Tara Humphreys. She's CEO of the Primary Care Consulting and is giving us a session on PCN development. So hopefully that will be of interest. If you've got any questions on how to develop your PCN or any queries, anything you'd be interested in, please let us know and we can submit them in advance for you. And we also have on this Thursday our Practice Manager Forum, where we're going to hear about the Practice Manager fellowships that are taking place. There's no other questions. Thank you very much, everyone, for joining us. As always, if you need any support, please do get in touch with us at the Liaison team, and we shall see you all next week.
Thank you,
Bye,
everybody.
everyone. Take care. Bye-bye.